Okay, good morning ladies and gentlemen. Welcome to the Free Market Foundation. I am Jasson Urbach and I'm a director of the Free Market Foundation and I'm responsible for its health policy unit. It's great to see so many people here today to discuss this very critical topic that's dominating our media at the moment and looming large in the healthcare policy space. A few months ago, I was really surprised to see this article that was published in the Business Day that indicated that the Director General of Health had met with the various healthcare funding associations in order to discuss innovative and inclusive ways that the various medical schemes envision their role under the proposed National Health Insurance Scheme. And I thought, wow, this is really a dramatic turnaround from the government's existing policy that was basically based on a single-payer, government-controlled, centrally administered policy that would have all but destroyed the private medical scheme market in South Africa. So I thought to myself, finally, some sense had prevailed. Alas, my enthusiasm was short-lived, and I was filled with a depressing sense of deja vu reading through the latest iteration of the National Health Insurance White Policy Paper, and the reason for that is simply because the policy is still based on a government-administered, centrally controlled, single-payer health insurance model, and we're no closer to understanding any of the material details, including but not limited to things such as how much the proposed scheme will cost, where the financing to fund the proposal will come from, or the scheme rather, and where we'll obtain the additional personnel, both medical and administrative, in order to staff this ambitious proposal. And I use the word ambitious on purpose because how else would you describe a policy that represents a substantial policy shift that will necessitate a massive reorganization of the current healthcare system? So reading through the policy paper, I was once again reminded about this quote by Professor Thomas Sowell, who said that it's amazing that people who think we cannot afford to pay for doctors, hospitals and medication somehow think that we can afford to pay for doctors, hospitals, medication and a government bureaucracy to administer it. So given the conspicuous absence of the material details underlying the policy paper and considering the timing of the release of the policy paper, we can only assume that this was a politically motivated event that will not materially improve the health outcomes of the poorest and most vulnerable members of society and may in fact do more harm than good. You would think that a program that requires extracting billions of rand out of taxpayers would be released at a time when there's an abundance of confidence in the future of the country, not at a time where uncertainty reigns supreme, unemployment is at an all-time high, and the economic growth forecasts are all looking dismally bleak. So I think my concerns were succinctly summed up back in 2009 by Professors Serfontein van der Berg and Heather McLeod, who at the time stated, "Our fear is that the proposed NHI will fail to meet the expectations of the poor, will leave medical scheme members, including the working poor, worse off, will be massively expensive or even completely fiscally unaffordable, and will require far more doctors and nurses than are available. The danger is that it could well become a highly costly failure that will further increase frustration with service delivery." Now, I think that for the purposes of today's discussion, this statement by President Jacob Zuma back in 2016, as part of his State of the Nation address, is pertinent for today's discussions. He said at the time, "To achieve our objectives of creating jobs, reducing inequality, and pushing back the frontiers of poverty, we need faster economic growth. When the economy grows fast, it delivers jobs. Workers earn wages and businesses make profits. The tax base expands and allows government to increase the social wage. We must act decisively to remove domestic constraints to growth." And boy, did he say about changing the domestic conditions. But I think his basic underlying premise was correct, and that is that economic growth is key. And here, I think it's important to note the following by John Cain-Berman from the Institute of Race Relations. He says that 15 years ago, there were 312 people employed in this country for every 100 on social grants. Now, because we've extended social security faster than we've generated jobs, there are only 86 people employed for every 100 on social grants. And the National Development Plan, which the National Health Insurance Policy Paper relies upon heavily, warned that South Africa might not have enough taxpayers to finance its social security commitments one day. And I think since then, the risk of running out of taxpayers has increased significantly. But I'll go back to what President Jacob Zuma said. I think he was correct. The solution is not necessarily to remove the social grants, but rather to get more people into work. So all of what I've been saying is basically summed up in this graphic, which is that the national health insurance puts the cart before the horse. And the single biggest issue facing South Africa at the moment is this chronic, persistent unemployment problem that we have, where 6.2 million people in the population are unemployed, and that equates to about 27.5%. But that's the official definition of unemployment, which is referred to as the strict definition by Stats SA. If you consider the fact that 2/3 of the unemployed have been unemployed for over a year, a much better reflection of what's actually happening on the ground is the so-called expanded definition, which includes discouraged work seekers. And those are people that have simply given up searching for work because they don't believe that there's any available. And if you look at that definition, we see that over 36% of the working age population is actually unemployed. And that equates to over 9.2 million unemployed people. One of the things, as a result of this massive unemployment problem, South Africa suffers from relatively low levels of incomes. And it should be noted that the twin evils of poverty and income inequality are inextricably linked to the massive unemployment problem that we have in this country. And another thing with this massive unemployment problem is that we have a really narrow tax base. If you look at the data produced by National Treasury and the South African Revenue Service in a joint publication, you'll find that, or you'll see rather, that 3.5 million people in South Africa account for over 99% of the personal income tax take. And obviously everybody pays tax because everyone pays VAT, but I'm focusing on personal income tax today because that's considered the main vehicle for financing national health insurance. Now, the Davis Tax Committee confirms that in order to fund the national health insurance scheme, the tax to GDP ratio would need to rise quite substantially. And here I'm reminded about this quote by Winston Churchill. He said, "I contend that for a nation to try to tax itself into prosperity is like a man standing in a bucket and trying to lift himself up by the handle." And what he was alluding to is that increasing taxes is counterproductive. And the irony is that the NHI Policy Paper actually acknowledges as much. It says that increasing tax rates may generate higher revenue, but only up to a point, above which higher tax rates are counterproductive and revenue may decline. This is largely as a result of induced changes in behavior, and some instances, tax avoidance and evasion responses that have negative effects on the morale of taxpayers and the sustainability of revenues. Well, I think there's a very good case to be made to state that we've already reached that point where taxpayer morale is on the decline, and that we can reasonably expect revenues to decline moving forward. And I think that's bolstered by the fact that if you look at the data, we'll see that household debt is today 50% higher than what it was 15 years ago. When you consider the revolt around e-tolls and now with the removal of the medical tax credits, I think, once again, there could be a very good case to be made to say that we've already reached that point that the policy paper referred to that I referred to in this previous quote. And when we combine all taxes, we see that many people in South Africa are paying upwards of 50%. In other words, for the first 6 months of the year, they're effectively working for government, and only from July onwards do they begin to work for themselves and their families. And this stat here was produced by our statistician Garth Zietsman, who said that in 1994, for every rand of tax taken by government, taxpayers kept 2.62 rand, whereas today they only keep 1.54 rand. Once again, the great kind of paradox in the NHI policy paper is that it actually acknowledges all of this, and it says that to successfully implement the NHI fund must be established through legislation, and sources of revenue for the fund will be through a combination of prepayment taxes derived from general taxes and complemented by mandatory payroll and surcharge taxes. But what I've been kind of alluding to throughout this presentation is that raising taxes has consequences because it interferes with the ability of individuals to pursue their goals. And the NHI policy paper correctly points out that economic growth is key, and it echoes what President Jacob Zuma said back in his 2016 State of the Nation address. And this is the white paper, the policy paper, says economic growth is needed to ensure an expansion of the tax base, and savings are important for economic growth. Now, one of the surest ways to boost economic growth is to reduce taxes and encourage savings and investment, because a lack of savings retards investment, and a lower capital to labor ratio reduces real wages and perpetuates the poor savings and investment cycle. So I think it should be clear that without investments to fund and establish new ventures that create jobs, the smaller the economy and the lower the economic growth rate will be. So I think government would do well to avoid inflicting further pain on taxpayers by increasing taxes at this point. So the paradox again is clear in the NHI Policy Paper, because it says a higher overall personal income tax burden would impact on the disposable income of households and on consumption expenditure and economic activity. I find it surprising that trade unions haven't kicked up more of a fuss. And we've actually seen the biggest trade unions in South Africa come out in support of the national health insurance policy or a single payer health insurance type of model. And the reason for that is that a payroll tax is ultimately and always borne by workers, either in reduced compensation or in lower jobs, or job losses rather. And the policy paper or the trade unions seem to have overlooked this particular point that was made in the policy paper, which says that payroll taxes raise the cost of employment and may have adverse effects on job creation. And I think forcing employers to do the right thing may be politically attractive rhetoric, but it will do wide untold harm to the South African economy by stalling an already a weak economy and deterring the job creation that we need in order to drive economic growth. And it would actually do precisely the opposite of what the National Health Insurance sets out to do. So whilst the NHI is supposed to increase access to medical care, it will undermine people's chances of economic success by either cutting their wages, eliminating their jobs, or eliminating their job prospects. And I think this quote, which was from Professor Anne Mills as part of her inputs into the 1994 Finance Committee, that was actually established by the Department of Health in order to advise on national health insurance back in 1994. And Professor Mills is the head of economics at the London School of Hygiene and Tropical Medicine. She said it's clearly financially unaffordable to university either the benefits currently on offer in medical aid schemes or free and complete in the public sector. Benefits would therefore have to be severely restricted. However, it's difficult to see how this can be achieved because the setting up of a universal scheme would raise expectations about access to care. Moreover, the scheme would put in place a financing mechanism before having in place the health service infrastructure to satisfy demand. Benefits would inevitably be unevenly available, causing justifiable grievance. So, from our perspective, we think that the only question the government should be asking is what is the best way to increase access to quality healthcare for the poor? And the only feasible, affordable, and efficient way to do that is for the government to pay the health insurance premiums for the poor. Government doesn't have to provide free healthcare for all because doing so is not a particularly good use of scarce taxpayer resources. You must remember that spending in one area of government necessarily comes at the expense of another. So, for example, if the government decides to dedicate more of the budget towards healthcare, that necessarily means that there's less money available for housing, education, policing, etc. So, we think that healthcare should have the same model as other constitutionally mandated rights, such as housing and education, where the government cares for the poor, but it leaves the private market alone. But if you read through the NHI policy paper, it seems obsessed with removing the so-called two-tier healthcare system. And I think the point to be made there is that we have a multi-tier system for food, housing, all sorts of things in life. But most of us recognize that in order to drive private restaurants, for example, out of business and introduce state-controlled food control, will not increase access to high-quality food or food at all for the poor. So in conclusion, I'd like to say that we believe that NHI concentrates power in the hands of the government, and it's acting as both player and referee, and it doesn't leave any space for the private sector to operate. And under NHI, or National Health Insurance, the government will control the availability, financing, and delivery of healthcare, and South Africans will no longer have any choice. So I think we're currently facing a very important decision. We can either choose a systematic deregulation of the private sector on both the funding and the provision sides, or we can choose even tighter controls, where all of our healthcare decisions are governed by the state from the cradle to the grave. I think we need the courage to identify the impending disaster and to correct these mistakes before they're made. Without much further ado, I'd like to thank you and introduce my friend and colleague from the Health Policy Unit, Dr. Johann Serfontein. Thank you.
Steph. Right, good morning, ladies and gentlemen. It's always nice to be here, even though I must say the topic is not necessarily one that currently excites us for the right reasons. So, first, we're just going to start off with a little bit of an overview of the NHI, just to look at what is essentially the same in the new policy paper than it was in the previous version. What's important to note is that we've been told of late is actually that this is a final policy paper that's been adopted by government, and it isn't open for comments or public inputs any further at this stage. So there will be no period for public submissions on the NHI white paper. What will happen now is there will be a series of draft bills which the public can then imply on. But so that makes it even more disappointing that the amount of public input that came after the green paper and the white paper led to very little change in the way that it was structured when it comes to a practical way of actually implementing it. I don't think the underlying premise of quality healthcare access for all, I mean, nobody can disagree with that, and universal healthcare as such, but one needs to look at the practicality of how we need to do that in the South African context, and that's something that doesn't seem to be considered in the white paper. So what's still the same from the previous versions is that it will be implemented through a single payer. Jasson also alluded to that. It will be administered in-house by government. You still have that single purchaser model. They do expand a little bit on that it will now be a strategic purchaser. And we'll go into that a little bit later. All South African citizens and legal residents will be covered. That's still in the white paper. It will be primary care focused. That's still the same. It will include preventative, curative, rehabilitative, and palliative services in the service basket. And then the expenditure, unfortunately, was still projected in 2010 values at 256 billion rand, and we're going to look at that a little bit later in slightly more detail. And then the growth figures in this costing, unfortunately, hasn't been adapted either. They're still between 2 and 5%, not taking into consideration that we're currently in a recession. Other things that remain the same. It'll still be funded through a variety of prepayment mechanisms linked to an individual's ability to pay. In this case, obviously, it'll be taxes, personal income taxes or payroll taxes. Your contribution will be mandatory. Your access will be voluntary. So you will still have the option of paying cash for health services outside of the NHI service if you choose to do so, and if you have the excess cash to be able to do that. Then you've got the situation where there will be contracting of certified and accredited public and private providers, and then there is the indication that private providers may opt out of providing services to NHI patients. Of course, with medical schemes only rendering complementary services, that will mean that you will have to have a strong cash base in patients to actually keep a cash practice running if you choose to opt out of seeing NHI patients. They talk about alternative reimbursement models as being the way to fund this. You're looking at capitation models. They're looking at diagnosis-related groupers for in-hospital payments. And they say there will be minimal fee-for-service patients. I know a private specialist will be paid on a capped per patient payment basis, which is adjusted for complexity, but it's fee for service will not be there. And then they talk about the gatekeeper model, so that is still there from the previous versions as well. You will have to follow the referral path. You start at the primary care clinic and you'll move your way up. So it's quite different from what happens in the private sector now, where if you feel like it, you can go see a private specialist without going through a GP or anything like that. And most medical schemes will fund it as such. And then, as I said, medical schemes will only to provide complementary services. Some of the other things that are still there is that the government subsidies and tax credits will be phased out during the implementation processes. They talk about the use of sophisticated information technology systems, and that will be a massive requirement if you need to have a national health system that's all linked up in one large fund. Is you're going to need a very, very big IT system to sort everything out. They talk about proactive risk management and fraud mitigation strategies, and if you saw the Business Day this morning, there was an article about the special investigating unit actually now collaborating with the medical schemes in starting to reduce the amount of fraud in the system, which is necessary. because yes, they talk about 7% of medical scheme claims are actually fraudulent. So that's a lot of money going out of the system that we really would want to keep in there for accessing healthcare services. And then they do talk about, and it was previously there as well, that you could have co-payments for not following the referral path. So you might have the option, or you might make the decision to go see a specialist directly, but in the NHI you will then have a co-payment to pay for that. Which then does mean to an extent that if you are more affluent, you will actually be able to have more access to healthcare services, which it's kind of odd because that's what they kind of want to avoid. They say currently that's one of the problems, and yet it's not really addressed in the NHI system in that you will still have that option. And then, so what has changed? They've actually went from removing the referrals to an NHI card. And I think they realized that the pure costs involved with that, if you look at how long it took the Department of Home Affairs to issue these new ID cards, it would have taken them about 40 years to issue the entire population of NHI cards. So at least that they realized. So that's been removed from the system. Then the merger of other funds, the RAF and compensation funds, has now been specified that it will only apply to personal health services. Previously it was just said they'll just dump both those funds into the NHI. And now it's actually limited to the personal health services that will be merged, which makes a bit of a difference, because then the NHI fund will obviously not sit with the 150 billion in liabilities that's currently lying in the RAF. They might, however, access some of the assets in the Workmen's Compensation Fund, who sits on about 53 or 54 billion rands in assets at the moment. So some of those might be transferred into the NHI fund. There's no longer a specific implementation plan in the white paper, so it is a little bit different. There were previously specific dates and things in there. At the moment, that isn't there as much anymore. So it's a little bit more vague when it comes to the implementation. And then some of the previous statements stating that not all services will be covered have also quietly gone away. It's no longer in there, although the underlying premise is still there that you will find that all services isn't going to be covered, and yet it's no longer specified as such. And then suddenly also there's no indication anymore of how visiting tourists will access healthcare. One has to assume that it will still be through travel insurance, but that somehow also hasn't been added to the new white paper anymore. And then there was VAT was largely discarded as a funding option for the NHI as well during in the new paper. It's now actually either personal income tax and the payroll taxes are the sort of preferred choices in that. So there's a couple of new additions in the white paper, and the first of these is that medical schemes in the run-up to the NHI will now be reduced to one plan option, which in itself is an interesting concept, because in a discovery environment you've got key care patients that pay 500 rands a month, and you've got your executive plan members that pay 5,000-6,000 rand a month, and yet you want to somehow bring those two groups of people onto one plan at the same payment level. And you've got to wonder whether the bottom guys will still be able to afford this access, and whether the top guys in turn will be happy with the service basket they might get in that. So it's going to be an interesting exercise to do something like that. Then they talk about Polmed and Parmed will be collapsed into GEMS as well. And I think there's probably a couple of hundred judges in South Africa that might have a thing or two to say about that. I don't know whether the politicians will say anything, but the judges might have a bit of a problem with that one. So we'll see how that plays out. And then they do indicate that the basket of services and the DRG price might be adapted according to the budget. Which then brings us to a point that if you start experiencing budget shortages in August or September of any given year, it could happen that suddenly service access can be vastly reduced. They will just say, oh, well, actually now we're not funding this at this stage. It'll have to wait until next year when there's funding available again. Which then brings you to a situation where people that previously had access to services in both the medical scheme industry and in the public sector, as it is at the moment, will suddenly not have access to a lot of these services anymore. And then, of course, when it comes to the prices as well, if you start dropping your prices because of budgetary constraints, how long before the service providers can no longer make ends meet in such an environment? So it's very important You need to consider the costs involved with providing a service, and if you just keep dropping the prices because the budget is now becoming a problem, that needs to be considered. One of the other main things they introduced was a contracting unit for primary health care. So that was established, and that's going to be used to do primary healthcare contracting. The district health office will be that contracting unit, and they will then provide all of these school health services, district health teams, the various clinics in the area will fall under that as well. They'll get paid a capitation fee per patient for care, and they will then render these services. So they will be the main contracting unit. And then there's talk now of a strategic single purchaser. It's no longer just a purchaser, now it's a strategic single purchaser. So that's a new addition as well. And then there's a lot of more detail on how they want to deliver the services in these various structures that they created, and some of the way providers will get paid, and some of the governance in there. So if you're looking at the NHI structure, you'll have the NHI fund, which will be pooling all your resources. You'll have some kind of NHI authority, which will be involved in the revenue collection, the negotiation, the purchasing. They will be setting clinical standards and clinical pathways of care and things like that. Then you will have that 4% increase in your general taxes and your payroll tax. And that's an increase in the rate. So you will go from the current 45% in the top rate will go to 47%. So that's kind of the indication that you get with that, and then the introduction of a payroll tax, and Jasson alluded to the problems that go along with that. So the NHI fund will distribute these funds towards the provinces, which will be distributed to the districts, which will then have your public hospitals and clinics, your private hospitals, and your private doctors will all be contracted in these units. Some of the major central hospitals will actually be sitting directly in the national sphere, so the tertiary hospitals in there. So they will be controlled by the national government in that process. And then on the side, you will have the medical scheme contributions and your medical schemes, and they will be providing complementary services. And we'll also look at that in a little bit more detail later. What is very concerning is that there are some quite inaccuracies that are used by the Minister and the Department of Health to motivate for the need for NHI. And I think it's very important that one does separate out what is truthful, what is not truthful, because we cannot say we need to radically change the system because this and that reason, and the reasons you provide are not actually 100% truthful, because it makes one wonder about the motivation for the entire thing. One of the first things we need to look at is the fallacies of funding. So what the Minister says is that 8% of GDP spent in healthcare in South Africa, is a large amount, and that the fact is that 4.4% of that GDP gets spent in the private sector, which only covers 16% of the population. So as a result of that, first step they're going to do is they're going to remove that 22 billion rand tax credit. But what it boils down to, even if you remove that tax credit, is that 3.6% of the GDP is being spent by private individuals on their own healthcare. So you cannot go and say we've got this pot of 8.5% and that needs to be equitably distributed amongst everybody, because you've got the concern that it is not actually government money that's being spent. It is private individuals spending their private money. So can you include that in a general pot and say we need to equitably redistribute it? Because those people are already giving up something, they're giving up a vacation, or they're giving up a more expensive car or house to fund their health care. So you cannot just go and then include that in a general pot. Some of the fallacies of service delivery, that one's out of place there, is the fact that the Minister keeps on going on saying that 80% of specialists work in the private sector, and the fact is 80% of specialists do not work in the private sector in South Africa. If you look at the HPCSA in 2015, they had 15,005 registered specialists in South Africa. The Department of Health employed 4,986 specialists in 2015, which means that at most 66% of these specialists are working in the private sector. But you need to take into consideration that every specialist that has immigrated in the past 20 years is still registered with the HPCSA in South Africa, because of the fact that it is very difficult to re-register when you come back from overseas. So you've got all of those overseas-based people that are still registered but not working in South Africa, and those then are counted as working in the South African private sector. So it's very important that we do need to consider facts like this, because you cannot say that there's an unequal distribution in the healthcare force and 80% of specialists, when in fact it's not physically possible for that to be the case. So we do need to be honest about these things if you want to use them as motivation for changing the healthcare system. Then some of the other fallacies of service delivery, you've got the utilization. Research has shown by Econex in 2013 that in fact between 28 and 38% of the population actually access private healthcare in South Africa in one form or another. The Stats SA General Household Survey last year also indicated that it was about 27.5%. So you cannot say the private sector consists of the 16% of the population belonging to medical schemes. You do need to take into consideration there is a larger proportion of the population accessing it. Normally it's usually just for primary healthcare services, but the fact is it's happening. If you look at the distribution of nurses, and this comes out of the Department of Health's own Human Resources for Health document, 62% of the currently registered nurses work in the public sector. When it comes to GPs, 63% of those work in the public sector. When it comes to hospital beds, you find 86,000 or 71% of hospital beds are in the public sector and 28% in the private sector. And the fact is that if you look at the bed numbers in 1976, these are, if you combine these two, that's exactly the same amount of beds South Africa had in 1976. And the government's share of that was quite a bit bigger in those days. So if you need to take into consideration that if it wasn't for the private sector creating beds, we would have actually had less beds now with almost double the population than we had in 1976. So there is a failure in government to actually address these kind of issues as well. And then the government's Human Resources for Health paper actually states that 59% of specialists work in the private sector, and that's a Department of Health document. So it's then odd to see that the political head of the Department of Health is saying 80% when their own department documents say something completely different. So you cannot then say there's this unequal distribution. And if you look at altogether, with between 62 and 72% of the public using public services, the number of providers actually are sort of in line with those figures, except for the specialists there. And the main reason for that is that the government is not currently funding specialist posts because they've got a more focus on primary health care. So that's one of the reasons for that to happen. Then one of the other fallacies is the fact that there's this idea that the private sector is actually stealing public staff. And if you look at the retention gap in healthcare professionals in South Africa between 2002 and 2010, we had 11,700 medical doctors graduating out of medical school, and in that same time the government only created 4,400 posts. So if it wasn't for the fact that the private sector took up these providers, where would they have worked in the end? Because the government didn't create any posts to employ them. And it's the same with your dentists and your pharmacists and your physiotherapists. The only thing where government actually created kind of a larger percentage of posts was in dietetics, where there's a relatively smaller retention gap. But the fact is that we're training healthcare professionals and we can't employ them in the state. And then we complain that the private sector is stealing the staff. So that's not necessarily the case. If you can't say somebody's stealing your staff if you don't actually have a post for them. So that's one of the other things. So the question is, why is there this general opposition towards the NHI? And there's a lot of talk in the newspaper again the other day that one of the Department of Health spokesmen said that it's very unfortunate that calling people all kinds of names if they oppose the NHI. And the fact is that opposition to NHI does not equal opposition to universal healthcare in South Africa. NHI is our current attempt at achieving universal healthcare, but there's a lot of people that would love to see universal healthcare in South Africa, but can actually see the practical problems with implementing NHI as the form to get to universal healthcare in South Africa. So it doesn't equal that if you're against NHI that you're against universal healthcare, and that's an important concept that we need to bring across as well. Because nobody can oppose universal healthcare for everybody. It's a very admirable thing to do, but one needs to separate out those two concepts. So the opposition usually comes from some fundamental flaws that are built into the NHI at the moment. And we're going to look at these in a little bit more detail just now. So the main fact is that the costing is still not done. We are proposing a system, and we're starting implementation of a system without actually knowing what it would cost us. So it gives you the idea that we're kind of going this route no matter what. And the question remains then, what if it turns out we can't afford it? What if we're halfway down this path and suddenly we don't have the money to support the policy that's been implemented? That's why it's very important. We need to do a costing so that we can see what it's going to cost us. Then the affordability of it as well. The Office of Health Standards Compliance, and we'll look at that a little bit as well. Every provider that wants to contract with the NHI fund needs to be accredited by the Office of Health Standards Compliance. And they've got some concerns of their own, which we're going to look at a little bit now. Then there's still this single payer model, and I think in South Africa, if you look at other single payer models of healthcare services, you've got the road accident fund, you've got the compensation fund. Those are not exactly exemplary, so why would the NHI fund suddenly be running very efficiently when much smaller funds are struggling to do so under government administration? The strategic purchasing premise, there's some fundamental flaws in that as well, which we'll go into in a little bit. And then, of course, the service basket itself, which is a little bit of an unknown at this stage. And then the last bit is what's happening with the medical scheme industry. So first of all, the costing of the NHI. If you look at the white paper costs, it's still in there, and that's why everybody's still going on about 256 billion rand being the magical figure. Of course, that's in 2010 funds. So if you just go and update that with the actual Department of Health spend that happened in 2015-16, and so now you're looking at 2016 values, then you're looking at 332 billion rands already in last year's money. So I saw in this week there was Econex had something in the business day as well where they said it's actually 378 rand in billion rand in 2017 money. So those are much bigger numbers. So we're all still stuck on 256 billion rand and thinking, how can we make that happen? Well, we need to make these kind of amounts happen. We need to make 378 billion rands happen in this year, which is huge. And then, of course, if you then adapt the funding shortfall, looking at a 2% growth line, which we're not anywhere close to achieving, then you're looking at a shortfall of 184 billion rand. Which is massive, and funding that with a 4% tax increase is just not going to happen. So that's why it's very important that we actually go and see what is the NHI going to cost us, and can we afford it? If we can't afford it, we need to look at different ways of actually achieving universal healthcare in South Africa and different models of doing that. And that debate is not happening. If you look at some healthcare spending projections, the white paper estimate there still in 2010 money. If you look at the combined public spending plus a private spending minus, say, a 30% discount. That was in the original green paper. They were talking about reducing private rates by 30% to make it a bit cheaper. And you look at a 3% annual increase in costs. By 2025, you would get to a budget of 372 billion rand. Now, we're definitely not going to be having 3% increases. Even in the white paper models, they're looking at that between 6 and 7% increases. So if you're looking at the current kind of increases in that sense, you're already looking at 587 billion rand in spend. And then if you don't take a discount on the private spending, then you're looking at just under 700 million rands for costing of the whole system. So definitely, it's huge. And the fact is that the reorganization of service delivery into a more primary focused model, along with, the pathways of care and all of those things, it will reduce the costs of delivering the services, but it's definitely not going to reduce it to the extent where suddenly the current state budget at an annual inflationary increase is actually going to be enough to cover all these services, because you're forgetting that half the money that gets spent in the private sector, in the healthcare system, and that just kind of gets ignored and saying we're going to service everybody on state funds as it is now, and that's not going to work. So if you want to look at costing and how it impacts on universal health insurance, you can look at the example of Ireland. So how did Ireland implement universal healthcare insurance? Fact is, they didn't. So Ireland published the Universal Health Insurance White Paper in April 2014. In September 2015, a costing analysis was published by the Economic and Social Research Institute in Ireland. And based on that costing, the whole ideal was actually scrapped as unaffordable. So then the question remains, why is South Africa not doing a costing exercise? It's very important that we say, listen, we're doing NHI, let's see what it's going to cost us. And the Irish model costing wasn't a comprehensive costing either. It had scenarios. It had a low spend scenario, a higher spend scenario, utilization differences and things like that worked in there. So they didn't have an exact number, but they could get an indication. And even the kind of low spend numbers they couldn't end up affording. And that we need to do something like that so that we can get to a point where you can say, well, we can't afford it, let's look at what else can we do to improve quality in the public sector and reduce prices in the private sector, because that is the main concern with the NHI, is those two components that need to happen. If you look at the affordability of the NHI, so what will the NHI cost? So you had that expenditure of 256 billion rand. The motivation for that was the current government spend, and they worked at a sort of a 3% GDP growth. Some of the unconsidered consequences of that, of course, is the recent credit downgrade. Suddenly government debt is becoming more expensive. We had a 0.3% GDP growth last year, so that's nowhere close to the 2 or 3% that they used, and currently we're in a technical recession, so we're not actually growing at all. The rand has depreciated 30% in the interim as well, so that needs to be considered. And then they talk about increasing the government spend from 4% to 6% of GDP, so which is also difficult because your government budget is obviously limited to about 25% of your GDP in South Africa. So you're taking a bigger part of the pie for healthcare, at the cost of something else. So somewhere else this money's got to come out of the budget, or you've got to borrow it, and you cannot borrow for operational costs. Just looking at the South African tax base, and Jasson alluded to that a little bit earlier, and if you look at the spread of South African taxpayers, you get that about 13% of your taxpayers earning above 500,000 rand a year, which is 1.7% of your total population, is paying just under 64% of your taxes in South Africa. So that is a very small proportion of people paying very large amounts of money over to government. And these are the people that can actually afford to go and live elsewhere. They can afford to immigrate to Australia or New Zealand or those places. So the question is, if the healthcare system comes to a point where these people get really unhappy with their access to healthcare, would they consider leaving the country? And if not too many of them leave, it's going to actually have a large impact on your tax base. And I think we're already noticing that at this stage, where SARS is saying, listen, they're struggling to get in the taxes they want, and they can't really explain why. And this is probably one of the reasons why, because you've got a lot of South Africans leaving the country, and their taxes are leaving with them. So suddenly SARS has to scratch here and scratch there to get money in, and this is one of the reasons, is the immigration patterns. So all in all, you can see that the 6.1 million taxpayers earning under 500,000 rand a year only pay about 36% of the taxes. So so they pay a relatively low proportion of it in total. So one does need to look at, it's not as socialist as the white paper, but the fact is that one needs to save the taxpayer in South Africa. We need to do as much as we can to keep taxpayers in South Africa to fund everything, because if we don't, we're going to have a problem to fund everything, not just healthcare. So that's something to consider. Some of the other middle income countries that our healthcare system gets compared to as well, you find Mexico. Mexico's got a tax base of about 37%. You've got Thailand on 29%, Brazil 25%, Korea also 27%, and then you've got South Africa, and this was in 2014. Got 10.3% tax base. So we're quite a bit lower than other countries that have implemented these universal healthcare models. Unemployment levels, of course, way down. I mean, the highest one on here is Brazil at 6.8%, and then we're sitting at about 4 times that. And this is 2014 figures, so this has gone up in the meantime. And your Gini coefficient. So having a tax-funded universal healthcare system You know, because other middle income countries have it, is actually a very poor comparison to make, because we're in a totally different situation, and South Africa needs to look at ways that we can address that in a South African context that would work for everybody here. You cannot say, hey, they're doing it in Thailand, let's do it here and it's going to work just as well as it does in Thailand. Even the unemployment rates, if you look at the OECD unemployment rates, Japan is right at the top there. They've only got about 3.4% unemployment. The UK with their NHS system, they're sitting at 5.3% unemployment. The OECD average is 6.7%. Turkey is one of the other countries we get compared to. They're sitting at 10.4%, and then South Africa is actually right at the bottom in this figure. They're sitting at 25.4%, and this was also then in 2014. So obviously, currently we're sitting at just over 27%. So you know, we got to consider unemployment if you want to have any kind of tax-funded healthcare system. It could be a problem. So the Office of Health Standards Compliance, for those of you that are not aware of their function, it was created by the Health Amendment Act in 2013. And the idea was to monitor and enforce compliance by health establishments with norms and standards prescribed by the Minister of Health in relation to the national health system, ensuring consideration, investigation and disposal of complaints relating to non-compliance. And I think recently the Life Isidimeni crisis actually brought the Office of Health Standards Compliance into the limelight a little bit, in that this function was called upon where they had to go and investigate what happened there. And then, of course, for NHI purposes, they need to inspect and certify health establishments as compliant or non-compliant with these norms and standards. And these norms and standards were actually promulgated on the 4th of January this year. So there's now a set of these regulations, and with that in place, you actually find that there can now be a little bit more of a stick approach to facilities not complying with these norms and standards. Of course, the Office of Health Standards Compliance are facing a couple of challenges on their own. As it is in the NHI setup, what they would need to do is they would need to inspect about 3,380 government facilities, about 3,200 private clinics, and between 31,000 and 74,000 private practices that would need to be inspected. And the indication is that this inspection certificate is only going to be valid for 4 years. So you need to inspect a quarter of all these facilities in any given year. Currently, they've got 7 teams of 5 inspectors. So 35 people in their inspectorate. If you look at their strategic plan going to 2020, they plan to increase it to about 60 or 70 by 2020. You know, so they're going to double that. But those ones will then have to inspect about 9,300 facilities annually, at least, and probably about double that. So if one looks at their current staffing and the way their kind of management is dealt up, the potential requirements that they would need to employ for this, you would have to look at probably about 157 managers and 811 inspectors to do these 9,300 facilities annually. And if you're looking at sort of a 74,000 private practices, you're looking at about 321 managers and 1,652 staff. So that's quite large numbers of staff that they're going to require to do this job. How we got to these private practice numbers is the 31,000 is actually the amount of providers currently sending claims into Discovery Health. So they're the largest medical scheme in the country. So that gives you a good idea. 74,000 is the amount of providers registered with MedPages. So somewhere in between those two is the amount of private practices in South Africa, depending on whether some of those practices only deal with cash and things like that. So that's how we got to those numbers. The Office of Health Standards Compliance didn't go that far to actually look at what it could potentially be. At the Health Market Inquiry earlier this year, they said, well, they don't actually know how big the private sector is. Last year when they were there. So, you know, I don't think that they've actually got a scope of the inspection that they're going to have to do to make the NHI work. So if you look at the Compliance Inspectorate budget at the Office of Health Standards Compliance, in 2015-16, they did 417 inspections in government facilities. Their total budget for the year was 34 million rand. So this is just the Compliance Inspectorate. It's not the rest of the Office of Health Standards Compliance. Their 2017-18 budget, they're looking at about 47 million there. And this is from their strategic plan, which means that in 2015-16, their cost per employee in the inspectorate was about 491,000 rand. So these are highly reimbursed people, and obviously they have to be skilled in order to get that kind of salary out of the Office of Health Standards Compliance. They are probably medical professionals mostly. And then their cost per inspection was about 23,800 Rand if you divide the costs up. So that is obviously your travel and transport and S&T and those kind of things for these inspectors when they travel to different facilities to inspect them. If you're looking at the 9,000 inspections annually, the employee compensation is going to have to jump up to about 475 million. And the total budget would go up to about 699 million. So just under 700 million Rand is what's going to have to happen with this budget prior to 2025 in order to have all these facilities inspected to contract with the NHI. If you're looking at the larger figure of 19,000 annual inspections, their budget has to go up to about 1.4 billion Rand. Now, I can just imagine if you're sitting in Parliament and it comes up that you've got to increase the budget of the Office of Health Standards Compliance by 2,500% for next year, how that will go down in Parliament, you know. So, so it's not going to happen quickly. And the other thing is, with these skilled professionals, you do need to realize that you cannot overnight go and acquire 1,000 inspectors. You know, it takes you time to build up that capacity. And if you haven't started now already, you're already behind. So that's really something to consider. And so that's the one end of it, is the private inspection. On the other end, you've got what's currently happening in government with the Office of Health Standards Compliance. So in 2014-15, and unfortunately the 2015-16 results are in a totally different format. So you cannot pull it out in this format. Somehow every year they change the format, so you can't compare it to the previous year and see whether there's actually been an improvement or not. Which is odd, because one would want to see that. Are we getting anywhere? But now it's a totally different format, so it's difficult to compare. So out of those facilities, you had 3.1% of facilities that were inspected that were compliant. Compliant with requirements was 3.6. Conditionally compliant was another 9.4. And then these ones of serious concerns has 4 months to rectify it, and we don't know whether that has happened at all. And then you've got these large swaths over here that are non-compliant or critically non-compliant. So that's a big concern, because if you're going to contract with the NHI, you need a certificate from the Office of Health Standards Compliance, which means those three categories are the ones that will be getting certificates, 16% of the public sector. Which then begs the question is, who are going to render the services in the NHI if that's what's happening in the public sector? If you go and look at the 2012 baseline government inspections, and you look at the 2016 results of the inspections, then you can see now that actually Gauteng has dropped from 69% to 55% when it comes to the inspections. All of them have dropped with the exception of the Northern Cape, which has a 1% increase, and Mpumalanga that had a 1% increase. So in general, there's actually a steady decline in the quality of public health. And one needs to urgently start addressing that, because even if NHI does come to fruition, one needs to address this in order for the public sector to be able to render services in the NHI. So I think definitely there should be a lot more focus on improving quality in the public sector at the moment than there is on implementing NHI, because otherwise it's not going to happen in any case. The implications for this on service delivery, of course, is that they say that public health facilities should be the backbone of the health system, and the private sector will kind of slot in a little bit on the side. But you've got 16% of public facilities actually being able to contract with the NHI fund. And then in the private sector, there's no capacity to actually inspect and contract with the private sector. So then the question remains, who will actually render services in the NHI? So the Office of Health Standards Compliance is going to be one of the major stumbling blocks in implementing NHI. And I don't think that there's enough emphasis put on that. And the concern is, of course, that obviously asking these kind of questions, it gets said, no, you're against universal healthcare. It's a pertinent question. It needs to be answered. Whether I'm opposed to NHI or for NHI, this is a question that needs to be answered. So it's very important that these things get addressed. Then we're looking at the single NHI fund, which is going to be looking something like this. I think one can probably replace that face with one of the Guptas at this stage, as things are running in government. So the NHI will be implemented through the single fund. It will be administered in-house by government. and they will have this single strategic purchaser model. One of the motivations for that is they say monopsony buying power reduces prices, similar to what a monopoly does with supply. Pooling of risk reduces healthcare costs. It's one of the other motivations for that. And then the NHI administration in Taiwan costs about 1% of their total spend. So that's one of the other motivations for going for a single funder, because apparently it's cheap to do. But if you look at the administrative version of this in South Africa, the NHI fund will basically be a large medical scheme to be governed by this ministerial board of trustees, non-prescribed set of benefits from a prescribed set of contracted healthcare providers at a certain cost. So you can imagine the NHI 25 times the size of Discovery Health, the membership of Discovery Health administered by government, similar to sort of Road Accident Fund, Petro, SA, SAA, SABC, Eskom, SASA, AXA, Sunroll, and the Post Office. And I'm sure there's a couple of more parastatals that will fit into that list. So it creates serious questions as to government capacity regarding state-owned entities and governing them in a fashion that's actually meaning efficient running of these facilities. This NHI fund will be the single biggest public entity in South Africa. I don't think that a lot of people have realized that, but this is going to have the single largest chunk of the South African budget is going to sit in one entity, which will be the NHI fund. And that's why, you know, the governance of this fund needs to be impeccable, and I don't quite know whether we've got the capacity in South African government at the moment to do that. This fund will be strategically purchasing services. Some of the questions that were raised by this decision, if the NHI fund is going to be setting prices and the government is setting prices, why do you need monopsony buying power to reduce prices? Because the price is set. You set the price. Whoever wants to render services needs to comply with that price. So why do you need a single purchaser then to kind of bring down that price? It just doesn't make sense. Because the two things are mutually exclusive to an extent. Of course, the next question is, where is the National Department of Health going to get their funding for administration? So on top of whatever budget goes to the NHI fund, there has to be a secondary health budget to fund the National Department of Health, because they don't render healthcare services, they do administration. So there's an additional cost involved with running that. That needs to be put into the system as well. Then there's the Provincial Department of Health. Same thing. They've got an administrative department that doesn't render services that needs to be funded by taxpayers, and that money needs to be put into the system on top of that. The district health offices, same thing. The capitation models are based on patient numbers in a specific area. It doesn't consider administrative functions necessarily. So that's something that needs to be considered. And then, of course, while Taiwan might cost 1%, the NHS costs 18% to administer. So there is other figures in this administration cost as well. Medical schemes who are running at breakneck efficiently are doing sort of 8 or 9% in costs for administration. So definitely, you know, thinking that it's only going to cost 1% is probably not really a reflection of what the costs of running this NHI fund might be. So the NHI fund will be contracting directly with hospitals. They will have functional business units that will serve as cost centers in these hospitals, and the hospitals will receive DRG payments. So diagnosis-related grouper, which means that based on the kind of disease you have, you will get a fee paid to the hospital to look after you when you get in till you get out, and that will be based on kind of normal levels of care for any specific condition. So that's more or less what's going to happen with DRGs. Then you've got these contracting units for primary healthcare, which will receive capitation payments, which is based on the age profile, sickness profile, size of the profile in any given area. And then the question of that is, of course, how is hospital administration funded? Because if your functional business unit is the one that's going to get this DRG payment based on what a patient, which sickness you have, the question is how's the hospital administration then going to be paid for? Because that needs to be paid out of some budget, and it might not necessarily be that one. And then the question is, where will these payments be made? Because you will have the functional business unit contracting with the NHI fund. Will the payment be made to the functional business unit? Will it be made to the hospital? Will it be made to the district or to the province? And will it flow from there? So the financing, the flow of money is quite important. And I mean, if you've got a functional business unit and that then needs to set up a bank account to receive these funds from the NHI fund, that could create some interesting situations if you've got a staff turnaround of the people who actually have access to the bank account, and the effects that might have on on what happens with payments in the system. And then the final question, and this is the very important one, is if the NHI fund payments fail for whatever reason, who pays the staff? Even in the government sector, you know, where do they get money from to pay the staff there? So this is a big thing, because at the moment in the private funding industry, you've got multiple payers. In 1 month, you might find GEMS is paying you a bit slow, but you still have 82 other medical schemes from which you see patient where the money comes in and you can cover your overheads and you can carry on. If you only had one fund worth of patients you see, and that fund suddenly has a problem and pays you in 70 days instead of 15, it creates a massive cash flow problem for a practice. And how do you keep your doors open? And in the state, so much more, because these functional business units might not have overdraft facilities and things like that, where they've got access to spare capacity funding. So in strategic purchasing, it's a way where services will be purchased where required. And the indication is that they might not contract with everyone in Sandton or Pretoria, say, because there's an oversupply of providers there. What they might say is they'll contract with half of the providers, but they will make contracts available in some of the rural areas. So providers will have the option of moving to a rural area and delivering services there, and then the NHI will pay you for your services. But if you've got 80 GPs in Sandton, they only need 40. 40 of them will not be contracted in the NHI fund, as it stands at the moment. So the question with this is, of course, is what will a provider do if he has to move to a rural area to go and practice medicine? If he's got to move somewhere to practice medicine, would it necessarily be a rural area, or will it be Europe or Australia or New Zealand? That's something, because if you're going to move, you're going to move. So, you know, might just go that extra step and move somewhere else, because rural areas, there's a reason the Department of Health is struggling to find people to work in rural areas. And it's not necessarily because of the hospital and clinic facilities. It might well be because of the fact that the social infrastructure isn't there. You know, there's no proper school for your kids to send your kids to, you know, entertainment-wise and all of those things. So there's a number of reasons for that, and it goes way beyond health in how do you get providers to go to rural areas. And then the diagnosis-related grouping payments to hospitals can only work if hospitals are employing specialists. It doesn't actually work in an environment where doctors are not employed by hospitals. So that's something else then that is going to have to come to the fore, is if you want this to work, hospitals will have to employ the doctors, which is not currently the case. There's the odd HPC has the other day given permission for the Life Healthcare Group to employ doctors in certain departments, but it's definitely not pervasive at the moment. And then the underlying large question there is, can one purchase selectively in an environment where there is a supply shortage? We don't have enough healthcare providers in South Africa. So do you have the luxury of saying that you're not going to contract with some of them because you've got a shortage? So that is quite interesting. And then if you look at the compensation fund itself as an example of a government administrated function that renders these services, 2013-14 they paid out 2.1 billion rand, 2014-15 1.4 billion, and then 2015-16 they paid out 2.6 billion rand, which was just under 900,000 claims, and they're employing about 1,200 employees. If you look at kind of Discovery Health's payments, you know, with 4 times the employees, Discovery Health is probably paying about 30% of the 30 times more claims than the compensation fund. So it's not particularly efficient. And then, of course, you've got the Radiological Society and 19 practices litigating for 120 million rand in outstanding claims. The average provider payment happens in about 70 days in the compensation fund. I mean, in the medical scheme environment, the law dictates that you need to get paid under 30 days. So if you go into an NHI space where the NHI fund pays providers at 70 days, you're going to have a big problem in practices having to pay salaries and overheads on a monthly basis, and income taking 70 days to start coming in. So it creates a big problem. And of course the NHI payments are going to be 100 times more than the compensation fund is currently paying, and that's of course in those 2010 prices, so it might be a lot more. And then the question is, if an 11 billion rand fund paying medical claims cannot be administered, how would a 256 billion rand fund be managed by government? So it creates a lot of uncertainty about how a single payer model is going to work. One of the other things is saying that the single payer model actually reduces healthcare costs, which is not quite true, because it reduces the underwriting costs of the lives involved. It doesn't actually do anything to service delivery on the ground. And one of the reasons for that is Baumol's cost principle, which is a principle that says that in rapid technological progress in a society, the costs of manufactured goods fall, but the cost of labor-intensive services rise as a result of that. So healthcare is a labor-intensive service, and a doctor can ultimately only work so many hours a day. So a doctor can't give you a bulk discount. If you say you're going to give him 100 patients, he can give you a nice discount, because ultimately he can only see 40 patients a day maybe. So whatever the other 60 you're willing to pay him for the other 60 is money that he can't get out of the system anyway. So that's why it doesn't do anything to the costs of providing these services. If you have this single payer model and saying you can enforce a bulk discount, it just doesn't quite work like that. So economies of scale doesn't work in the service industry, in the healthcare industry as such. So the risk pooling reduces the cost. It doesn't reduce the cost of delivering healthcare, only the underwriting risk. So that's something that we need to take note of. When it comes to the basket of services, it does say in the white paper that services will not be based on a negative or a positive list or a PMB type of package. And then it says that the NHI priority setting will go through explicit guarantees using gatekeeping at primary healthcare model, referral systems, clinical guidelines and protocols, and health technology assessments on the process of priority setting. But then we alluded to it earlier, there are indications that services can be adjusted based on the budget, in which case you may well find that certain people had access to services now in the state sector, and as a result of this priority setting and the adjusted budget, they might not have access to these services going forward. In which case, is it achieving universal healthcare if people now actually have access to less services than they previously did? And then, of course, where does this leave us from a costing point of view? Because if you do not have a basket of services, how do you decide what your budget is supposed to be to render these services? And that's why the indication was kind of as well that they would just adjust the services according to the budget, which makes it very difficult, especially if you start running out of budget towards the end of the year. Then there's going to be real rationing of services, and with medical schemes having to cover services that are not covered in this basket, then suddenly in August they've got to start covering all these other things which are not worked into their premiums, and it creates an interesting environment there. With medical schemes, of course, the indications in the white paper, PALMED will roll into GEMS. They're talking about the removal of tax credits, the reduction of scheme options to one per scheme, and then ultimately schemes will only provide complementary cover. So complementary cover and only complementary cover then creates a couple of pitfalls, in that what happens to the indigent population that have these rare diseases or require services not covered in the NHI, because they now cannot afford medical scheme premiums. What happens to them from a service delivery point of view? So that's something that we need to take into consideration. Then there's also the underwriting impact of a radical reduction in the number of medical scheme members. The less members you have, the higher the premiums are. So, if you pay additional taxes for NHI, you might not be able to afford a medical scheme. And then, of course, the underwriting impact of an unknown basket of services. The medical schemes can't cost a premium if they don't know what they need to cover. So you need to know NHI covers these services, medical schemes need to cover the rest. Then the actuaries can sit and work out what they're going to be covering, and of course it's bound to be expensive diseases to treat, which means that these premiums in the medical schemes are going to be quite high, and they might well be unaffordable as well for a lot of people. One of the interesting facts regarding the kind of involvement of medical schemes is that you've got the minister there's kind of a flip-flop going on regarding the complementary services and having a multi-funder model and things like that. Because on the one hand, you've got the Director General of Health that's busy engaging with medical schemes, and they're talking about how schemes should be involved in the NHI. And on the other hand, you've got them placating COSATU in the process by saying, no, we're only going to have a single funder model. So there has to be some political consideration in this as well. Unfortunately for them, they're caught between a rock and a hard place, because as it is with the pitfalls of a single funding model, they have to look at multiple funders, but they can't let that out in the open, because then COSATU is going to hang them up. So you've got to pity them to an extent, because they are in a very unfortunate situation when it comes to that. But that needs to be dealt with, you know. So the whole COSATU thing is a little bit of a political issue, in the sense that, you know, COSATU obviously is in alliance with the ANC, so they need to try and keep them happy. But on the other hand, you've got the practicality of not being able to get rid of medical schemes. And then on the other side as well, you've got the average COSATU member that actually might have a thing or two to say about firstly, their tax credit being taken away, and then secondly, if they talk about government subsidies for GEMS patients and things like that being taken away as well, you know, that impacts your cost to company and your income. And I think that union members might have a thing to say or two to say about that, you know, because while the union leadership might be saying one thing, the average member on the ground might be quite happy on his medical scheme and being able to access services using that. All in all, the government's NHI position centers around 5 flawed assumptions. The first one of those is that the government has the fiscal resources to implement the NHI model. At this stage in the economic climate that we're in, it's highly unlikely that we're going to have enough money to implement the NHI, and we really have to start looking at other ways of achieving universal healthcare outside of this. And if the two main premises are improving public sector quality and reducing prices in the private sector. Prices in the private sector, I was at the BHF conference over the weekend, and the indications are that if you make it mandatory for all employees to belong to medical schemes, you immediately drop the premium prices in medical schemes by about 20%. So just doing that would mean that you actually reduce the costs in the private sector almost overnight. Then there's other ways of looking at different reimbursement models and things like that. So all in all, you can probably squeeze about 30% in savings out of the private sector just by doing things a little bit differently. But that would mean you have to adjust the legislation a little bit as well. And you know, one gets the idea that the political will is not aimed at doing that at the moment, because suddenly if the private sector is now a lot cheaper, how do you then justify for implementing NHI going forward? The second flawed assumption is, of course, is that NHI is the only available model to implement universal healthcare in South Africa. And I think that's a debate that we need to have, is what are the other models we can use to get universal healthcare? What happens if NHI fails? What is plan B? And what can we do even now? Because a lot of the things in NHI are implementable in the current service. The primary healthcare, community outreach-based teams, school health teams, all of those things, there's no reason why they can't be implemented in the current system already. One doesn't need to reorganize the entire funding model in order to implement those. So that's something we need to have these conversations, because we're all focused on NHI, but if NHI fails, what then? And we can't have that conversation 10 years from now when it fails. We need to start looking at other ways of doing things now already. And then, the implementation of NHI is required to improve quality in public health services. Good management will improve the quality of our health services. If you look at the Frere Hospital in the Eastern Cape, it was in an atrocious state. That they got a very competent manager appointed there, and suddenly Frere Hospital is doing a lot better. So it's not a question always of not having enough funding or not having enough staff. Often management, getting a proper manager in a facility can make a huge difference. Cleanliness and things like that is a function of management. It's not a function of money or of staffing necessarily. So these things can be adapted already in the current system. One of the other things is that the implementation of NHI is required to reduce costs in the private healthcare services. That's not necessarily the case. There's a lot of legislation that can be adapted that can then reduce the cost. Like we said, mandatory enrollment. Then you've got PMBs that haven't been reviewed in years. If you review those, you might find that there could be cost savings in there as well. Changing the way we treat PMBs as well, because it's quite hospice-centric, which makes it expensive. Let's try and prevent those from happening That will definitely reduce the costs. And then the last flawed assumption about NHI is that the private sector is opposed to universal healthcare. Often you find the private sector is opposed to the NHI, which is not universal healthcare. It's our version of universal healthcare. So that's something that we do need to separate out those two, because the private sector is very much in favor of universal healthcare because it's admirable and it's the right thing to do. But NHI is not going to achieve that for us. So in conclusion, the World Health Organization says that universal healthcare systems need to be affordable to the country that implements it. They don't specify free healthcare for all, and they don't specify a single payer system. So that's something that South Africa chose to do. And ultimately, when it comes down to it, the NHI model is just not right for South Africa because it will not achieve these universal healthcare objectives, and it's not affordable to South Africa. So we need to start looking at what else can we do to implement universal healthcare in South Africa, as the NHI is unlikely to reach that. Thank you very much.
We'll take a few questions. Don't disappear. Oh. Don't in the hot seats up there. Hi.
Johann, I remember reading a couple of years ago about a study that compared the costs of procedures in the private and the public sector. And at the time, for a hospital procedure, they found that it was only about twice as expensive in the private sector. I mean, that's what it cost. Yep. It cost about twice as much, and of course the outcomes were much better. Is there any more recent work done along those lines, comparing the actual costs with the outcomes?
Yeah, unfortunately not. Outcomes measures are few and far between in the private sector, and definitely medical schemes are moving more towards value-based reimbursement. So they are starting to take note of these things, but it's quite difficult. There isn't a lot of outcome measures, unfortunately. And if you look at sort of cost comparisons, I mean, the OECD report that was used in the health market inquiry, you know, was ripped apart by the local economists and things like that, because they were comparing private sector prices in South Africa to combined public and private sector OECD prices and a whole lot of things like that. So unfortunately, no, there hasn't been a lot of comparison. The minister does anecdotally use like the odd example of circumcisions and things like that are a lot more expensive. And at the BHF Congress, one of the fund managers actually said they really would like to see where that 50,000 rand circumcision came from, because they've never seen anything like that, you know. So one has to wonder about these figures because they're anecdotal, but no, there aren't unfortunately any more recent on that. The main problem is that it's very difficult to cost services in the public sector, you know, because you've got the Department of Public Works owns the building, they do the maintenance, you know, so that's a totally different cost unit that's responsible for some of those, so it makes it very difficult to do the comparisons.
Yeah, I think that was the point that I was going to make. It's that we don't have any real cost data that's coming out of the public health service, so you can't compare apples with apples. So it's very difficult to make any comparisons. But I know, I think it was Sylvester van der Berg and Heather McLeod did some calculations a few years ago, and I think they calculated that it was 5% higher in the private sector, but the outcomes were significantly better. So your duration of stay and all of the outcomes were just much better. Chris?
Yeah, I just wanted to say, firstly, congratulations to both of you for an excellent summary of the current situation. My concern is that, you know, I believe you're talking to the converted, and the concern is how do we get these facts accepted, firstly, or out of the public domain? Because using the press and press statements and these sort of things may have that ability to communicate with a wider audience, but they have a very negative impact on the Department of Health, who are very sensitive to public criticism. And I just wonder whether we shouldn't be trying to find a mechanism of directly communicating and speaking to the minister. Doing this presentation in his office, I mean, I've been in his office where there have been 4 people present, himself and myself and 2 others. So he is amenable but he's also, as you have demonstrated, he's under enormous pressure. He's not two-faced. I mean, although he would appear to be, because he's got these very different constituencies that he's trying to placate and appease. So that's my concern: is how do we get the reality of what you guys have been saying in a discussion with him face to face?
Well, I think there's two things there, and there's a reason people go to church every Sunday, even though they know what the Bible says. It's that reinforcing. So the fact that everybody's here today, it plays a very important role, and it's to go out and also to spread the message, right? But I think the idea is to change the climate of opinion on the ground and to put the facts out there so that people have the intellectual ammunition to make cogent arguments and say, look, we don't think that the costing's right. Where's the funding going to come from? So that people start asking those questions of their councillors and things like that, and where they live. And then the other side of the thing is to take it from a top-down type of approach and do exactly what you're saying. And we've had a lot of debates, especially in the public domain, with yourself included, with the minister, on a lot of these issues. So I think it requires a multi-pronged approach, and there's no one-size-fits-all that's going to actually kick this thing into touch and to get people to understand that it's simply not a feasible type of universal healthcare model that South Africa is currently pursuing. I don't know what your thoughts are, Johann.
Yeah, no, I can't really add to that. I think that pretty much covered it. Yeah, it's a difficult situation. That one needs to think how to do that, and probably the private approach might be the way to go, because yes, we are hammering the minister a little bit in the press, and it does look bad, and potentially the way to go about it is to actually approach him face to face, where it can be a private conversation, and he might be a little bit more open in a sense like that, than if you attack him through the press. So it might be something to do as well.
If I could just make one other comment. I mean, Johann and I think the other people in this room were at the BHF conference the last few days. Now, BHF appears to have made a public statement to the effect that they support NHI. But, and we've been at all the BHF conferences in the last few years, and there has been this collective response, but there's been no real debate on the real issues as have been illustrated in these talks today. Those discussions aren't taking place. I mean, what will be the impact on scheme members of their scheme only providing complementary services? We're not even talking about it.
Well, Dr. Clarence Minnie was on a radio debate or a panel discussion with Johann on last week Monday. And as you said, the BHF have been fully supportive of the national health insurance for a number of years. And I've always found that such a bizarre, counterintuitive kind of stance. But the admission that he made during that discussion was that they actually support a multi-payer system. So, which was really bizarre. And I mean, once again, that's a complete turnaround to what the previous kind of staff members at the BHF were putting forward. So I found that very interesting. Jack, I think you're next.
Thank you. I've got two questions. I mean, how likely is there to be a legal challenge? It seems to me to be unconstitutional freedom of trade, and you're putting it's your private money, I mean, that sort of thing. So what do you expect on that front? And the other thing, what the government could do, of course, is the 20 billion rand odd from your tax credit. That seems to be an easy money to plunder, and obviously I think COSATU is going to be the big opponent of that, ironically. But the government could do that. I mean, they can say, well, look, we're providing the subsidy to the private sector, we're just going to take it away. I mean, that's, without doing anything else, and that in itself could do immense harm.
Yeah, look, I think if you speak to Neil Kirby at Werksmans, he's busy preparing quite nicely for the implementation of all of this, because he's got about 5 or 6 constitutional points that he reckons one can fight successfully, and hold the system up for years if you do that. And And definitely there's going to be legal challenges, and it's not necessarily, because people are opposed to universal healthcare. It's because certain portions of it just do not go in line with the Constitution. At some stage there was talk of the medical scheme, the current, what do you call it? The money sitting in the medical schemes, the reserves, being taken out and put it into the NHI fund as well, which is private money from private individuals. So that does not come across in the new white paper as much. But there's a number of these things that they do reckon can be challenged legally, and it can hold the process up for years and years and years. And I think once one starts actually getting acts implemented regarding this, one might find that those start happening. When it comes to the tax credits, it is very concerning because it's going to impact on your sort of middle income people that are currently on medical schemes and can only just manage to afford it. If you take away that tax rebate they get, you might find that it becomes unaffordable, and then they're actually going to end up as a burden on the state. And until the NHI is actually implemented and looking after these people, they now have to fall into the state system. And I mean, once you pass the tax threshold, you actually start paying full fees in public services. So it could actually mean that they suddenly don't have access to healthcare anymore because they can't afford those full fees and they can't afford the medical scheme on the other side. So it puts them between a rock and a hard place. So it's a difficult decision to make that, and it looks like it's easy money, but it's going to have consequences for a lot of people in the process.
Yeah, just on the issue of the tax credit, I think the government's been really good at putting out this narrative that it's a subsidy, but it's not. You can't be subsidized with your own money. All it means is that the government's taking less of your own money, and you're generally not relying on the state for those services. So we need to kind of make sure that we speak in the same language. And Johann's 100% correct. If you take away the medical tax credit, it will increase the cost of medical scheme membership, and you'd typically find those at the margin will fall out, and those are people that tend to be younger, healthier individuals that are cross-subsidizing the older individuals. So it has massive actuarial implications for what happens to the existing pool of people within the fund. And then when you introduce the national health insurance mandatory payments, so the surcharge on taxable income and the payroll tax, that's also going to have a massive wave where you'll see a lot of people dropping out again at the margins. And the irony is that the government is, as I alluded to in my presentation, they're obsessed with removing this kind of inequality and two-tiered system within the public health in the healthcare system. But what it'll do is it'll exacerbate inequality, because you'll have more people relying on the already overstretched public healthcare sector and less people involved in the private medical scheme. And if they can't get their access to quality care, they're just going to go hop on a plane and go somewhere else, like what a lot of African heads of state tend to do currently. So it'll increase inequality in healthcare in South Africa. It's not going to reduce it.
No alternatives have been suggested by either of you two. What are the alternatives for universal healthcare?
Look, there's the social health insurance initiatives that the SAPAF actually had an alternative in their white paper submission that we presented last year at a grouping. But a lot of the social health insurance initiatives that were there in the 2000s and suddenly were scrapped, those combined with a bunch of other things would actually make a big difference. So you can look at, if you make medical scheme membership mandatory, you can look at a sort of a 20% saving. Then you introduce those low income medical schemes as well to help the employed that are not quite earning enough for the normal medical schemes. What one then does along with that is you do a mandatory gap cover, which then looks at those hospital co-payments, which are the big thing hitting people at the moment as well. And then the proposal was that those 20% savings you get out of the mandatory cover, instead of passing it on to medical scheme members, you actually pool that money in a separate NHI fund, and you use that to fund primary healthcare services for South Africans in the private sector, for everybody currently using the state. So you pay that money to GPs in sort of forms of capitation, and they look after community members currently accessing the public health service. And if you do that, you can actually increase the amount of people using the private sector, and if you can do that, it would actually give the state a chance to get their quality levels up, because they're not as overburdened as they was before, and you might well find that the system can then kind of correct itself. And the moment the state as better quality services, it can actually start being a competitor for the private sector, and you can find that medical schemes can then start buying services from the state because now the quality is sufficient that their members will be happy with it. And that way you do get access of public members into the private sector, and you will then eventually get it going the other way around as well when the quality is sorted out. So that's one of the alternatives that is there.
I think the most important thing is that you have to deregulate the private sector, because at the moment, just for argument's sake, if you look at the cost of providing PMBs, it's over 600 Rand per individual on average per month. That immediately blows out a large proportion of the population, because that's a politically motivated package of service benefits that every single medical scheme option, irrespective of your age or disease burden, has to provide. So if you can amend the PMBs, and I think for low-income benefit options, and to get more people enrolled in private medical schemes, which will remove a large part of the burden on the public sector, you have to get rid of the PMBs altogether. So low-income, low-cost benefit options or low-income medical schemes simply shouldn't have to provide PMBs and things like that. And then obviously there's other things like certificates of need in the hospital environment, where the government's taken this stance where in order to set up a facility within an area, you have to prove that there's need. Now you're using your own private money to set up. You taking the risk. It's not like you relying on a subsidy or something from government to set up a private facility. And those certificates are like hen's teeth at the moment. Another thing is to allow the private sector to increase the supply of doctors. So we've been producing about 1,500 doctors in South Africa since about the 1970s. And that's despite the fact that our population's more than doubled. We suffer from the so-called quadruple burden of disease. And the government just has this kind of iron fist grip on training doctors in South Africa at the 8 government-run medical schools. Now, there's been a big demand, obviously, to increase the number of doctors, but there's also been a willingness on the part of the private sector to train doctors in South Africa. And it's not that the existing public sector positions will become less affordable, because Minister Motsoaledi has made comments saying like you can then kiss goodbye people from rural areas and that becoming doctors. That's not the case at all, because it's not going to diminish the number of positions available at the 8 government-run medical schools. All it's going to do is increase the number. And private sectors, there's no reason why they can't offer bursaries, for example, to people that excel in their... So there are a lot of various things, but basically you have to deregulate the private sector to allow more individuals to start taking care of their own personal healthcare requirements. Sorry, I don't know who was first there. I think you may have been dressed.
I think the majority of us in this room agree that NHI is not the way to go. Is there anything being planned or being done to mobilize like-minded people to speak to whoever needs to hear the message to ensure that this doesn't go forward?
Well, I think this is part of what our plan is, and I mean, I don't know how many interviews you've been on in the last few days, but I've certainly been on a few on radio discussions, and we've got quite a lot of coverage in the popular press, so Independent Online and Business Day and things like that. And then I'd encourage everyone here to write letters to the editor and do things like that. I think that would mobilize a lot of the kind of intellectual ammunition.
And of course, on the 1st of August, there's a business briefing as well on NHI, and I think it's one of the groups of stakeholders that have really kind of ignored NHI up to now. You know, we haven't really heard anything from business, and I don't think business realizes how it's going to affect the way they do things. So one needs to get the business sector involved and updated in the implications of this for business. And I think once that happens, you'll find that there will be a little bit more pressure from different sides, because at the moment, you know, the pressure groups are kind of different and few and far in between, and the department kind of ignores them. But if you get somebody big like big business on board, you know, might well find that, you know, that they can start raising these issues as well in the various forums they have with government.
Perhaps not in this forum or platform, to find out what it is that can be done. I come from a civil society organization outside, and we've been instrumental in acting very much with regards to the state capture, and I think we might have a few ideas that we can scratch around with regards to how we can reach the people that matter. The gentleman alluded earlier to actually going to the office of the minister and presenting to him or speaking to him. I think radio coverage and media coverage only goes so far before you need to actually go to the source and speak.
That's a good point. So yeah, chat to either one of us, and we'd be happy to have you at our business briefing on the 1st. It's a selfless plug, but we've got Paul Harris that's doing the keynote address. You'll remember him from First Rand Foundation, and he's also a member of the high-level panel that was set up by ex-President Kgalema Motlanthe in order to advise on certain policies in South Africa that may be hindering growth. Then we have Neil Kirby from Baxman's Attorneys, and then Johann's going to present again. And then we also have Marinee Erasmus from Econex, and that's all happening here on the 1st of August. Sorry, I think you may be next.
Just an observation, the surplusing graduates could become inspectors, so that might solve a problem there. But you alluded now to the business sector getting involved, and we chatted earlier about the possible apathy or ignorance from business of what's actually coming. In a lot of sectors in business, we've had, like childcare, having in-house creches and nursery schools, that kind of thing. I would imagine that something like that is going to start being developed for people to take care of their own staff, especially in large corporations and mining companies. Is there any type of stop-style or in-house managed approach to this as an alternative, other than creating pressure towards the government, being independent in your solution?
Look, I think the mines are doing a lot of that kind of thing already, so you've got the mining hospitals and they employ doctors and things to look after their staff. Companies, not so much anymore. But I mean, that would be an option. But I mean, obviously you're limited to kind of primary health care and preventative things, and that would actually be quite good, because if you can start preventing some of these diseases, often it reduces the costs of managing them on later. If you look at high blood pressure, monitoring your blood pressure and keeping it down is a lot cheaper than managing you after you've had a stroke a year or two down the line, because then you get hospitalized, you end up in ICU and things like that. So definitely prevention. Of course, one of the things is the norms and standards that the minister promulgated would actually apply equally to all healthcare facilities, whether it's a school nurse or whether it's a 500-bed hospital. And some of those are quite onerous. So you might find that companies that want to set up these things are actually going to run into some barriers when it comes to that. Because just as a stupid example is, every healthcare facility needs to have access to a morgue facility. So you've got to have a place to store dead bodies. If you have a nurse in your company, you need that facility, or you need to have a contract signed that says you're outsourcing it to somebody should that happen. So things like that, they don't take the regulations don't take into consideration smaller healthcare facilities run by a single person, because you also have certain HR requirements. You need an HR plan, you need a disaster management plan, there's a whole host of things that makes it quite onerous to have a small little facility just with one or two people. But definitely that would be the way companies can approach this, because you might find that sort of waiting times and things like that under the NHI, it might just be more prudent for you to have an in-house doctor or nurse to look after your staff, because they're not going to be out of the building for 6 hours in a day to go and see a nurse then for something, So that's probably going to start becoming more pervasive.
Reverse the figures from 4,600 medical practitioners and 265 dietetics practitioners, get 4,600 dietetics practitioners, and you won't need that system.
Yeah, so definitely.
Just one comment. What no one has really mentioned has been the rather unspectacular results and statistics of the NHI pilot areas. The maternity results, maternity deaths in particular, have shown no correlation at all between extra money spent in those pilot areas and reducing deaths. So it isn't as if there's an easy success to point to show, to validate NHI.
I actually mentioned, I was supposed to mention it during my presentation, and I had it written up there, but I just skipped over it. But if you look at the stats from the Office of Health Standards Compliance, they revealed that I think 89 out of the 1,400 facilities, the NHI in the pilot district, actually passed. And what it showed or demonstrated was that the NHI pilot districts were failing to improve any faster than the rest of the country. So these are supposed to be the flagship kind of pilots where the government's trying to promote and put all of the money in, but then they're not actually improving any faster than facilities in the rest of the country. Yes. Yeah.
And I think one of the other things there, of course, is if you call it a pilot, I mean, none of those are actually piloting the funding model, which is the main crux of the NHI. So what they need to do is they need to pilot that. They need to start running the compensation fund like they would run the NHI fund, and put all the governance structures in place and all of that, and see if they can actually get that running up to a point. Then you can say, right, we piloted the funding model, or at least the payment, the single payer kind of system and that, and then you can say, listen, let's then increase the size of that and see how it goes. But, so that's not being piloted at all. But the pilot projects here, and it's abnormal because they're spending a lot of money on improving the facilities and things like that in those pilot projects, and yet they aren't getting the results. So it really makes you think that is management not the big problem in those?
To what extent will the NHI mimic the NHS in Britain?
Well, it's supposed to be mimicking it, but if you look at the NHS in Britain, their budget in rand terms is about 1.25 trillion rands a year at the moment, and they've got the same amount of people as South Africa. So obviously, costs and things like that are different, but it's supposed to be sort of a similar system in a sense. But of course, Britain got a lot more taxpayers, and they've got a lot less unemployed people, so you've got a very large pool of people contributing. So ideally that would be what you're working towards, but you do need more people paying than you. Currently we've got a lot of users and not enough payers, and that's the big concern.
They've got a GDP per capita that's 3 times greater than ours, and I read recently that they're in a funding crisis. They're basically bankrupt, and I think they were requesting a bailout to the tune of, I think it was 156 billion or something like that. So the NHS is in crisis. It's not not a model you want to be emulating.
Yeah, and
the dentists are not included in that NHS.
The NHS.
The dentists.
Yeah, dental services are generally, that's why British people generally don't have great teeth. Because yes, that is one of those services that you have to pay for privately. So a lot of people don't do that.
Eustace?
Something that hasn't come out in the discussion is that when you talk about so-called free healthcare, the demand increases and the inclination to pay declines. So that's a double whammy in the whole process.
Yeah, I think what also kind of went unconsidered in the white paper is where they were talking about costs in the private sector. They were mentioning, that PMBs drive up costs, and there's various things driving up costs. And yet the one thing they didn't mention was utilization. And increases in utilization has been shown at the health market inquiry to be one of the major cost drivers in the private sector. So the government, in a sense, is not willing to admit that utilization is a major cost driver. And the fact is that if services are suddenly free, what is that going to do to utilization? It's just going to skyrocket from there, because there is a lot of pent-up demand at the moment. So suddenly, people, that's why when private hospitals build beds, suddenly they're filled, because there's a pent-up demand for it. It's not like the hospital creates patients. The patients are there, they're just not being serviced. And hospitals themselves don't admit patients. Doctors admit patients. So doctors don't have shares in these hospitals, so, it's no skin off them whether the patient gets admitted or not. But if it's required, then, that's why those hospital beds get filled up as soon as they're built, because there is a lot of pent-up demand, which is going to come out if suddenly healthcare is free.
Yes, behavior changes totally. People who look after their own healthcare, don't go to the doctor, don't get prescribed medicines, they will be demanding the services.
Yeah. Yeah, definitely.
Yeah, it's a classic. If you think Peter's getting free healthcare, or Peter's paying for Paul, and Paul thinks he's paying for Peter's healthcare, neither of them have an incentive to control their medical costs. It's a classic. So I think you're right there.
Are there any other questions?
Yes, just the last thing about medical training.
Yes.
Isn't there a need, you're talking about the amount of doctor trainees has increased. Isn't there a need, I heard some time ago that in China they had, or somewhere in Asia they had foot doctors. Isn't there a need to create a separate medical school, as it were, for doctors just to in basic
Look, what has happened is that there was a category created. I think it's called a clinical assistant, or something like that, which is a mid-level healthcare worker, which was being trained, and they do things sort of in casualty and things like that, you know. So they do these kind of mid-level tasks somewhere between a doctor and kind of like what a nurse does, almost something like that. And yet, despite the fact that 250 of these individuals were trained, there were just no posts created for them. So now you've got these trained people with a level of skill that can be quite nicely used in the primary healthcare clinics that just doesn't get employed. But yes, definitely things like that, you know, and I mean, that's why the primary care focus would be also on nurses quite a lot. But I mean, of late, we've been closing down nursing colleges, you know, so we're not training nurses like we used to in the past. So it creates we're creating our own shortage of staff to an extent by closing down schools, not allowing for private training. And what we're trying to do as a solution is trying to send medical graduates to Cuba to get trained there. And when they come back, they still need 2 additional years of training. So suddenly the medical schools, I think next year or the year after, they're going to have a big problem, because they're going to have like 500 extra medical people that they need to fit into their final year classes because of these returning Cuban students. And then, of course, you need to create posts for them. So you need to create internship posts, you need to create community service posts. And that hasn't been happening either. I mean, this year there's still people now that haven't gotten their community service and internship posts yet because, okay, well, some of the posts are in odd places, but some of them there's just nothing available. And that, you know, it creates a problem. And from a training point of view as well, to train specialists, you need registrar posts. And those are funded because the person works for the state while you're training to be a specialist. And those posts are not being created, and they go unfunded. And you find, like in KwaZulu-Natal University, they can only train 3 ophthalmologists there at this stage because there's no funded posts. And the government there says, listen, if somebody private is willing to pay for this person to work there, then they'll fund it. Then they can train him. But other than that, you know, there's just no money for a funded post to train specialists, and that's a big concern, because you can raise the output of medical students as much as you want, but you need to create those government posts to actually employ them.
Yeah, one of the great ironies in the policy paper is that they talk about not outsourcing anything. So they don't want to outsource the laundry services, the food services, things like that. At any of the facilities, but they're quite happily to outsource the training of doctors to Cuba, and these doctors are trained in a completely different language, completely different disease profile. They come back here, and you basically got to reteach them, make everything from the bottom up. So, yeah, it really is a bizarre situation that the government has this hostility towards the training of doctors within the private sector, despite the fact that there's this willingness and they have world-class facilities, and it could have attracted additional professors from overseas and staff, pupils rather, to come and train here. So with that, I think we'd like to close and thank everybody for coming. If you are available on the 1st of August, please come to the business briefing. Thank you.